Good morning to everybody, and thank you for participating in the SIOP Global Health Network Partnership Working Group meeting. I think that the idea of this meeting is to follow this agenda, so we are introducing the meeting. We are going to discuss a couple of things about an initiative called the Partnership with the Continental Branch, and later we are going to have our speaker to do some presentation that is going to be quite interesting. What we are trying to do with the Partnership with Continental Branches is an initiative in which we are trying to get in contact with each particular Continental Branch and be able to get more information and get communication with them about what they are doing and about what we are doing. I think that is the best way for the moment that with Nita we are seeing that will be a good interaction. The idea is that this could be the common ground when we can talk, we can communicate, and at the same time, the different areas or the different continents may know what they are doing in other places and communicate each other through the partnerships groups. In one particular moment, the expectation is that this partnership may produce some interaction that could be academic, it could be at different levels, and that at the end of the day is going to, or the expectation or the final goal is that they will produce more partnerships and there will be more connection between everybody. So Nita, I think that there are some issues with the network, so I hope so that you can listen what we are saying, but that's the overall expectation. So I don't know, Nita, do you have any comment? I cannot hear if any one of you has any comment, and I don't know if there's any particular Continental Branch that has already been present and made to want any comment or may provide any information for all of us. In case that's not, I would like to introduce Dr. Federico Antillon from Guatemala. He is a physician, PhD. He has training academically in Spain and also in St. Jude Children's Research Hospital. He has been an instrumental component for the twinning program in Central America. Currently, he is the director of the unit for Pediatric Oncology in Guatemala. And he's going to talk to us about Pediatric Oncology in Guatemala and Central America, past, present, and future. And Federico is the incoming co-chair of the Global Health Network in SIOP. So I think that we are quite grateful that Federico has taken time in his busy schedule to stay with us and to communicate with us some ideas, and we will appreciate that. Susan, I think that we have to open to Federico, please.
Hello, good day to all. Thank you, Cesar. I will try to explain in the following minutes the journey that we have done in Guatemala and Central America for the last 25 years or so. there you go. I'm going to share my screen. Please let me know if you can see the slides. Can you see the slides? Okay,
Yes.
thank you. Thank you so much. The learning objectives for this presentation is to understand the challenges of developing a pediatric cancer center program in a limited resource setting. I'm sure all of you have had more or less the same experience as I had. To understand the importance of global collaboration in curing pediatric cancer and understand the impact of education and research in a limited resource setting. I have nothing to disclose. So Guatemala is a very small country, roughly the size of the state of Tennessee. As a curiosity, we have 37 volcanoes, which of 3 are active. The 2 on the slide are the Fuego volcano, which means fire volcano, and the Pacaya volcano. Just for you to have a taste of Guatemala, we're a really small country, only around 100,000 square kilometers. We have a population of almost 18 million, and our population is really young, as you can see. And our median age is 23.2 years. So this means we're still in a growing mode here in Guatemala. Although we're supposed to have a high middle income, a country with a per capita income of around $9,000 per person, but the distribution of this is not equal for everybody, as you can expect. We have an expenditure of the government of around 6.5% of the total governmental budget. We have a low physician density, and but everybody has access to mobile phones. So we have 126 mobile phones per 100 persons here in Guatemala. The past, we did a retrospective study between 1990 and 1995 here in Guatemala, and we found that there was not a specialized pediatric cancer center in the country. We only diagnosed at the time 100 cases per year. The abandonment rate of treatment from the public hospitals was 42% of the kids did not finish their treatment, and less than 20% had a survival at 3 years from diagnosis. So our starting point was a really sad situation for Guatemala. Then we started to work, 3 physicians, Dr. Sandra Luna to the right, Dr. Patricia Valverde, who was trained in Spain, and myself, to start dreaming about how we could start a program here in Guatemala. Really close also Dr. Pedro de Alarcón, which joined the team in the early days and continues to work and be a mentor to us in the program here in Guatemala. So we established a foundation, which is a UV Foundation. Back in May 1997, we established relationships with the Ministry of Health of Guatemala, and also we continued the relations with St. Jude Children's Research Hospital. In that time, it was the International Outreach Program. So we were able to open the unit back in April 2000. Early on, several companies from Guatemala and international companies joined the effort. And as you know, we opened the unit in 2000. So we're going to divide the talk in 3 distinct areas: patient care, research, and education. Here's the actual unit. We have 3 facilities. The one in the top is UNOP in Guatemala City, which was the first one to open. The one in the middle is an outpatient clinic in Quetzaltenango, which is the second city of Guatemala. This part of the unit works from Monday to Friday, and the idea is that the patients that are on continuation therapy don't have to come to Guatemala City to receive the continuation chemotherapy. And the one in the bottom, Ayubishela has 6 years, and the one on the bottom is Hospice Care Hogar Estuardo Mini, which opened 8 years ago. So this is part of the installations that we have now. We renovated part of a public hospital, which is called Roosevelt Hospital, and this is specifically for pediatric patients, the unit. The Hogar Estuardo Mini has 10 beds, and we have been able to take care of more than 300 patients here on terminal care. IUB Occidente, 6 years. And the average cost of treating a child with cancer in Guatemala is around $60,000. And the treatment has no cost for patients and their families. Around 60% of the budgets come from the foundation, and the other 40% of the budget comes from the Ministry of Health. Our patients, most of them, 90% of the families have an average monthly income of less than $250 per month. So this is a very low income, so the patients don't have the capacity to pay. Another problem that we face is that 50% of our kids, when they come to diagnosis, they are undernourished, so they have either a moderate or severe malnutrition at the time of diagnosis. We have also late diagnosis. 35% of our kids come with advanced disease at the moment of diagnosis. Culture is complex in the sense that we have 23 different Mayan languages, and sometimes communication. Most of the people speak Spanish, but communication sometimes is difficult because sometimes we need to translate the information to the families. And 70% of the families live inside the country, and sometimes with poor communication to the hospital. So since we opened the unit in 2000 to June 2023, we have evaluated more than 11,000 patients, and we have been able to diagnose almost 9,000 kids and adolescents with cancer. We treat here at the unit up to the age of 18 years. So we include adolescents in the cancer program. The distribution of the diagnosis, most are cases that we see are acute leukemias, which is comprised of 46% of all our cases. Lymphoma is the second diagnosis, 12% of the cases. We have a high incidence of retinoblastoma, 8% of our cases. We don't have an explanation for this, but this is a phenomenon that we see in Latin America, a high incidence of retinoblastoma and low incidence of neuroblastoma. So up to 2019, before the pandemic, we diagnosed more than 500 kids with cancer, but due to the lockdown in the pandemic in 2020 and 2021, we had less diagnosis because the patients were not able to move around the country. But this is starting to pick up now, and we think that this year we will reach again 500 cases again. So if we see the overall survival for all the kids that enter a curative intent, we have seen several eras, and more or less up to 2014, we cured around 67% of the cases, but after that we had a decline. This is in part due to the pandemic, and in part due to economic crisis, so the patients were not able to reach the hospital in adequate times. For acute lymphoblastic leukemia, we use a BFM-based chemotherapy with more or less good results. As you can see, standard risk, 84% survival at 5 years, intermediate risk, 65%, and high risk, 44%. At this time, we didn't have access to bone marrow transplantation or very sophisticated chemotherapy like Blina or other technologies used to you, like RTC, obviously we don't have here in Guatemala. So we presented this back in SIOP in 2014, I believe, in Ireland, and we won the prize for pediatric oncology in developing countries. We have a flow cytometry since 1998, but now we have a state-of-the-art flow cytometers. And for the first time this year, we have been able to establish minimal residual disease light for B lineage, which we're going to start to use this year. And in the next year, we wish we will try to have full MDR evaluation for B lineage and then develop the MDR for acute T-cell leukemia. We have good results in many of our protocols. One of them is Hodgkin disease, that we have a very good survival of the patients in the 3 arms of treatment. One of the things that distinguishes the Unidad Nacional de Oncología Pediátrica is we have a strong department which we call integrative medicine, which is psychology, child life, social work, and palliative care, which considers the unique condition of each patient and their family. And this has led to a decrease in the abandonment rates and have the family involved since the beginning in decision making of the treatment of the patients. So we have been able to decrease abandonment rate from 42% to less than 1% in the last 5 years. So this is more or less the route that we take. We have the initial consultation for psychology and referral. The patients get psychoeducation in the first 24 hours and social work evaluation. Then after we get the pertinent information, we do the diagnostic communication with the psychologist. And depending on the severity of the disease, the palliative care team is involved since diagnosis. We get the consent for treatment, and after that, the kid is referred to child life. So this has been very fruitful. We started a program of education and training for cell stem transplantation with a team from MOSA, with Dr. Marta Berna and Dr. Andrea Bioni from Italy. And this year we started with autologous stem cell transplantation in the context of acute myeloblastic leukemia. This was thanks to 2 grants for education, the Erasmus Plus in Europe. So we were able to train our personnel. This is part of the nutritional team, part of the psychology team, child life team, part of the nursing team, which are really excellent nurses. So as a summary, we have 82 beds, which include 9 ICU beds and 50 step-down ICU beds, and 4 isolation rooms specific for stem cell transplantation. The beds that we talk about hospice care. We have 24x access to clinical lab, pharmacy, blood bank, hemodialysis and immunofiltration. And we have access to almost all the specialists that we need to take care of the kids with cancer. So this has been a lot of work during the past years. So as a summary, UNOP is the only specialized pediatric cancer center here in Guatemala. We're treating 500 plus cases per year. Abandonment rate is low, and the survival rate is around 67% at 5 years from diagnosis. This has been highlighted as a cross-sector model, public-private enterprises in several articles that we have been able to publish. The last one was a workshop that we did with Pan American Health Organization that highlights the opportunities for innovative finances through cross-sectors model, including the private sector and civil society, which for Guatemala, it has been a real great combination. So what about research in this setting? Guatemala, as you know, is very rich in Mayan heritage. 50% of Guatemalans are pure Mayans. And as you know, several studies in the US have proved that Hispanics fare worse in the treatment of acute lymphoblastic leukemia. So back in 2010, we were able to establish a relationship with Dr. Jan Jung from St. Jude, from the pharmacy department. And with him, we started to study the genetics and the pharmacogenetics of acute lymphoblastic leukemia. And up to 2021, we have been able to recruit more than 700 patients in this study. And this study has given rise to several very important publications and research in the context of acute lymphoblastic leukemia in patients with Latin American heritage. Specifically, we have been able to describe several Philadelphia-like genes in the Guatemala patients. And the last publication was in January 2022. This was a joint study with COG, with a cohort of patients from St. Jude Children's Research Hospital, and also patients from Malaysia and Singapore, and patients from Guatemala. This is the cohort of COG, which has Hispanic patients. This is the cohort from Singapore, Malaysia. They obviously didn't have Hispanic patients. The cohort from St. Jude and the cohort from Guatemala. So if we look specifically at the patients from Guatemala, the patients that have a Native American ancestry above 75% have a different genetic presentation with very high incidence of chromosoma Philadelphia, high incidence of Philadelphia-like genes, low incidence of ET W6RONX, formerly known as TEL-AML, and this what happens with these patients is that if they have an ancestry equal or above 75%, their probability of survival is around 50%. And if they don't have this heritage, their probability goes up to around 70%. We also have been able to look about pharmacogenetics in Guatemalan patients. As you know, most Asian patients and Hispanics have a tendency to have myelosuppression for 6MP and thioguanine. So we were able to study the NUT15 gene in the Guatemalan cohort in patients from Singapore and from Japan. And we have been able to show that the Guatemalan patients also have this NUT15 polymorphism that affects the metabolism of 6MP. Regarding Hodgkin lymphoma, we have a different type of Hodgkin disease in the sense that our patients are very young, most of them. This is a study done jointly with Stanford, studying 42 patients with Hodgkin's disease less than 6 years old, and in 97.5% of their genome, malignant genome, showed the presence of EBV expression, which we think is really interesting. We have done studies in retinoblastoma, trying to see why we have a higher incidence of retinoblastoma. This has been led by Dr. Sandra Luna. Also, treatments that are more specific for patients with retinoblastoma in Central America, that we have a tendency of late diagnosis. So the strategy is double. One is early diagnosis, but if the patient comes in late stages, we have adapted protocol for these patients also. We have done studies with St. Jude using an early warning scale to detect sepsis in the context of pediatric cancer patients. And this started here as a pilot in Guatemala, and then, as you know, the EVAT or Pew scale, which is known in English, has extended all over Latin America, and it's extended to other countries. We did show that applying the EVAT scale to detect early possibility of sepsis and septic shock, we had less deterioration events. We had less patient stays in the U.S. because the patients are transferred early to the intensive care, and we were able to save money by doing this. So and we continue to do it, and this has been extended to other countries. As you know, the psychosocial program is very strong. We have published about socioeconomic status scales, how to tackle abandonment, and other studies here in Guatemala. But lately, we have been involved in research collaboration, in research communication research collaboration with St. Jude Global and Dr. Jenny Mack from the Dana-Farber Cancer Institutes, and have been able to study several aspects of communication between the teams, between the clinicians and the patients, in order to improve the communication and how to not only give diagnosis, but the teams to communicate in order for the patients to be the best possible as they can be. Regarding nutrition, we have been interested in nutrition since the beginning of the program very early, because as you know, we have this problem in undernutrition at the moment of diagnosis. So we have done several studies around Central America and in Guatemala, also studying traditional and complementary medicine with Dr. Elena Las. And more recently, we have been evaluating the nutritional status with DEXA scan using densitometry, bone densitometry, and calculating fat mass and muscle mass. And we have shown that it's more or less the same trends that are seen in other countries. And this is the newest study, which is a multiple national study on nutrition, doing biobanking, studying the stools of the patients to study the microbiome and also the DNA and RNA of the blood of the patients. And this is just has started. It's a big study with patients from Guatemala, Tanzania, Honduras, Brazil, Nepal, and Kenya in conjunction with IARC in France. This is an ongoing study. Infectious disease is also strong. As everybody, we have problems with multi-drug resistant bacteria, gram-negative bacteria. We're very emphatic and obsessive in hand washing. We have established federal guidelines for the patients of Central America, and we have also involved in the global study done by St. Jude Global studying COVID in cancer patients. Nursing is a real important component for us. We have a nursing education component, and we have been able to establish joint commission standard in some aspects of nursing practice. So at the end of the day, we have been able to publish around 100 papers, international peer review articles, book chapters, and we have ongoing active investigations. Regarding the education, since the beginning of the program, we detected a shortage of pediatric hematologists oncology in Central America. So jointly with AOPCA, with St. Jude Children's Research Hospital, and with Francisco Marroquín University, we established a pediatric hematology oncology fellowship in 2003. We have been able to graduate around 40 graduates until December last year, and we also had the help of our friends from Milan and from Mosa in Italy. This is a 3-year program. It is based on the content given in the United States. They have local rotations in pathology, flow cytometry, ICU, palliative care, and radiotherapy. And they go to St. Jude a couple of months to deepen their knowledge in leukemia and solid tumors and bone marrow transplantation. Since this year, they are going to the University of Colorado to have a 1 or 2 month rotation in benign hematology. They also go 3 months to Italy, and depending if they like leukemia lymphomas, they go to MOSA, but if they're going to be more focused on solid tumors, they go to the Tumor Institute in Milan. Scholarships are paid by St. Jude. And we also started an additional training program in January 2003 for intensive pediatric intensive care unit. So since the beginning of the Pediatric Hemo Fellowship, as you know, we graduated 40. 98 of them continue to work in hematology oncology in Latin America. They come from several countries from Central America and South America. Now we have 13 in training for 5 countries. And since the beginning of the fellowship, we have been able to double the number of pediatric hemonc specialists in Central America and double the number of patients diagnosed with cancer in Central America in the same period. So this has had really a very important impact. This is the last SIOPCA that we have in February 2020 before the pandemic. Then we have like 2 or 3 virtual meetings after that. And this year we started to be in person again. This is many of the graduates that came to Guatemala and that meeting. This is the fellows from 2020, and these are the fellows for this year. And for the first time, we have a fellow from Belize, which is a country which is by the side of Guatemala. They don't have any pediatric hematologists or oncologists, and hopefully we will train more people from Belize in the near future. So we also started a fellowship in a pediatric palliative care that started this year. We have a fellow, a pediatrician for Chile. This is a 1-year program, the same as the United States. And our program was accredited by the ACGME International Chapter in Pediatric Oncology as of July 2021. And this November, we will have the reaccreditation visit to continue to be accredited by ACGME. And with the collaboration with Daniel Moreira, which leads the educational component of St. Jude Global, we contributed to develop an assessment tool for pediatric hematology oncology training programs with other colleagues around the world. Another educational initiative is this MOOC. It's a Math in Open online course, which is free, which is an introduction to pediatric oncology. This is an online course. It's in Spanish now, but we wish to make a version in English. We did the filming during the pandemic in September 2020, and we're up to our 5th edition of the course right now. I think it has had a really great impact. This is the countries, 28, it has reached 28 countries that are highlighted like in blue and light blue, including countries from Africa and from Europe, Spain and Georgia. But it has more impact, obviously, in South America. And to the right, the top 10 countries that have been students from these countries. In the first edition, we had 969 students. On the second edition, 1,000 students. On the third edition, a little less. And it continues to have students, and we're going to launch the next edition this September. To talk a little about Central America, this is the Central American Isthmus. And talk about the Central American Hematology Association of Pediatric Oncology and Hematology, which was founded in Nicaragua in 1998, originally with 5 countries, Nicaragua, Honduras, El Salvador, Costa Rica, and Guatemala. The first meeting was held in Montelimar, Nicaragua, and it was created with the aim of curing children and adolescents with cancer and other blood diseases to promote shared protocols and clinical guidelines within the region. Initially, it was integrated by nursing professionals, surgeons, psychologists, social workers, and pediatric hematologists, oncologists, but it has continued to grow to include pathologists, infectious disease specialists, neurosurgeons, radiotherapists, and also clinical lab. It also had in mind education and clinical research. Since the beginning in 1998, we have continuing our upcast through the years with no interruptions despite the pandemic. The pandemic was virtual, as I told you, and we have weekly meetings to discuss the different protocols and to present patients. So it's very active. This is Central America for you to geographically situate yourselves. Initially, there was a program in Nicaragua, La Mascota, with the people from MOSA that started in 1996. Then the people from MOSA organized a meeting in Milan in 1996 and 97. Most of the pediatric oncologists from Central America met there, and we started the OPCA initiative. Panama joined in 2001, Dominican Republic in 2002, and Haiti in 2014. So we were born with a philosophy of education, research, and patient clinical care. Now we share several protocols, as you can see on the list: Burkitt's lymphoma, rhabdomyosarcoma, Wills tumor, retinoblastoma, the acute leukemias, other solid tumors, and the latest two are neuroblastoma and hepatoblastoma protocols. We had, since the beginning of the program, a lot of mentoring with very experienced friends on the leukemias on the solid tumor side. Here to highlight the collaboration of Dr. Raúl Ribeiro, Dr. Andrea Bondi, Dr. Stephen Unger, and Valentino Conter, and also Dr. Giuseppe Macera, which is now retired. Pathology has been also very intensive in training our pathologists on how to better diagnose the pediatric cancers. We started the pediatric registry back in 2013 with El Salvador and Guatemala. Costa Rica had a pediatric cancer registry very complete since many years ago, and Nicaragua and Honduras joined the initiative a few years later. So we have been able to establish better pediatric cancer registries within the region. We are also collaborating with CLEOP, which is like a Latin American consortium for research. We share the Hodgkin's protocol, and we also have been started with the APL protocol. We collaborate with SIOP and also with the Teleo Initiative for Education. And we hope that our moonshot for the next 20 years for the Central American Consortium is to increase the survival rates of 80% of the children to up to 80% of survival. This is very ambitious, so we hope to make it. Future projects for UNOP. Our hospital is saturated, although we have 82 beds. We have an occupation of 100% always. So we're planning for the future. As you're going to see in the moment, we need to reach this 28% of children in Guatemala that we are not able to diagnose right now. This is based on the number of pediatric kids. So we estimate based on the kids that we see, and we estimate that around a third are still not diagnosed in Guatemala. So the idea is to build a new facility in the next 5 years, so we can appropriately treat our kids with cancer. So I'm open to questions. Thank you very much for letting me share the experience here in Guatemala. Thank you so much.
Thank you, Federico. This is quite exciting that you have showing us what has been done through the time. Give me 1 second. And this is amazing the way that the program has developed, and you have been quite instrumental in that development, and also they speak quite loudly about what partnership means, all the interaction through the time. Are you open to any question for the audience?
Yeah, hi, Federico.
Hi, Nita.
Wonderful discussion. Hi. So, what I wanted to ask you is, like, when you started off, a lot of other than the doctors and the nursing and the training that you gave, when it comes to laboratory colleagues, did you have central review of radiology or central review of pathology to start off with? Or how did you manage? Because a lot of colleagues will not be tuned to reporting bone marrow, so for example, or reporting radiology. So radiology is a challenging field for new centers. So how did you overcome that?
For the imaging review, we didn't have a centralized imaging review, but as I mentioned, we had weekly meetings with mentors from developed countries, experts in like rhabdomyosarcoma or retinoblastoma. For example, for retinoblastoma, the RedCam images were sent to Dr. Matt Wilson in Memphis for, discussion of the patients. So discussion of patients is very intense. This was since the beginning of the protocols with AOPCA, but this has become more sophisticated in the sense that, for example, in neuroblastoma, now we have central review in El Salvador. The pathologists from El Salvador have been specifically trained for being better in evaluating retinoblastoma. So we are in this prospective study that the people we were trained from pathologists from San Jude and all the Central American countries are sending the samples to neuroblastoma. So we wish to start this initiative with other solid tumors in Central America, but it's like dynamic process. We continue to become more sophisticated because, as you rightly mentioned, Nita, this is a problem for everybody, and I'm sure everybody has had the experience. So this is a continuing work. For flow cytometry for acute leukemias, we send the samples to San Jude at the beginning, the first samples, and to compare our diagnosis with the flow cytometry diagnosis at San Jude. And we are doing the same for minimal residual disease. We have been able to standardize the MDR light, and now we're in the process of standardizing the full MDR for B lineage. And then we will continue with B lineage, but it takes time and a lot of passion from the different components of the team.
Wonderful. And congratulations also for all the research that happened parallelly. And
Thank you.
You got to publish all this, because many a times you get so bogged down by the work that research takes or publications take a backseat. But you have chronicled the whole journey very well, and it's very inspirational. Thank you.
Thank you so much, Nita.
Federico, there have been a couple comments in the chat. Congratulations. And also there's a comment that mentioned the way that research has been incorporated and good quality research has been incorporated. So I see that this is very important.
Thank you, Cesar.
I would like to know if there is any other colleague that wants to make any comments. If not, Federico, again, thank you very much. I see that has been quite an inspiration and see the development for people that we were able to meet Giuseppe, Macera, and the other colleagues and to work a little closer to them. This is amazing. And it's incredible the way that has developed. And also is, as you pointed, is a step that in any way that can be helping to get bigger. I think that is important to do it. And I think that Pedro de Alarcón and Sandra. They have been quite instrumental in these things, and I think that this is very important. I do remember Pedro helped me when I arrived for the first time to the United States, so this is very interesting. Okay, dear colleagues, thank you very much for your participation, and I think that if there are no more comments or questions for Federico, I think that we are going to close the meeting. In some point, I heard that sometimes you don't see many people. The most important that you see the right people. And I think that sometimes that happens in this meeting where there are not huge amount of individuals, but the most important is that they're coming the right one from different places. Thank you, Federico. Thank you, Susan. Thank you, Nita. Thank you, the colleagues that they have been able to participate in the meeting today. And we will see you in about 1 month.
Bye-bye. Thank you so much.
There should be a recording, Susan. So if you
Thank
could share.
you. Yes. Yeah, we'll do the usual. Yeah. Thank you, everybody. Bye.
Thank you,
Bye-bye.
Susan.
Have a great
Bye.
day.
Take care, guys. See
Bye.
you.
Bye-bye.